Let me ask you something that most people never think about. What if the medical test you agreed to just to be safe ended up causing more harm than the disease it was supposed to find? Imagine this. You are 72 years old. You feel good. You still go grocery shopping. You still cook your own meals. You still visit your family. Maybe you still drive, walk, garden, or enjoy your quiet routine. You are not feeling sick. You are not having alarming symptoms. You simply go to your yearly doctor's appointment because that is what responsible adults do. Then your doctor looks at your chart and says, "Let's run a few tests just to make sure everything is okay." That sentence sounds harmless. It sounds careful. It sounds like prevention. But sometimes, especially after 65, that one sentence can open a door to something much bigger. Extra scans, biopsies, procedures, anxiety, medications, complications, and treatments that may never actually improve your life. My name is Dr. Amanda Collins, and on this channel, I help adults over 60 understand their health in a clearer, calmer, and more practical way. Not with fear, not with confusion, but with honest explanations that help you ask better questions and make wiser decisions with your doctor. And today, we need to talk about a topic that many people are never properly taught. After a certain age, not every medical checkup is automatically helpful. That does not mean screening is bad. It does not mean doctors are wrong. It does not mean you should ignore symptoms. In fact, many tests save lives when they are used at the right time, for the right person, and for the right reason. But after 65, and especially after 70 or 75, the equation changes. The question is no longer only, can this test find something? The better question becomes, if this test finds something, will treating it actually help me live longer, stronger, and better? That is where many people get trapped, because modern medicine is extremely good at finding things. Tiny abnormalities, small nodules, slow-growing tumors, mild blockages, borderline numbers, small changes that may look scary on paper but may never become dangerous in real life. And once something is found, it can be very hard to leave it alone. One test leads to another test. A scan leads to a biopsy. A biopsy leads to a specialist. A specialist recommends treatment. Treatment creates side effects. Side effects require more medications, and suddenly a person who walked into the clinic feeling perfectly fine is now living inside the medical system. This is what I call the longevity lens. When you are younger, aggressive screening often makes sense. If you are 45 or 50 and a test finds a serious disease early, treatment may give you decades of healthier life. But when you are older, the balance between benefit and harm becomes more delicate. Three things matter more with age. First, some conditions grow so slowly that they may never affect your quality of life. Second, the body becomes less forgiving. A procedure that a 50-year-old recovers from quickly may be much harder for someone in their late 70s or 80s. Third, the emotional and physical burden of follow-up testing can be real. Anxiety, hospital visits, anesthesia, medication interactions, falls, infections, and loss of independence are not small details. They matter. So today, I want to walk you through 5 medical checkups I believe older adults should think carefully about before accepting automatically. And the first one is a very common one. Checkup number 1, routine colonoscopy after age 75, especially if you are low risk. Now, I want to be very clear. Colonoscopy can be an excellent tool. It can detect colon cancer. It can find and remove polyps. For many adults, it has been life-saving. But after a certain age, especially for people with no symptoms, no family history, and previous normal colonoscopies, routine colonoscopy may not always offer the same benefit. Let me give you an example. Imagine a woman named Helen. She is 76. She has always been responsible with her health. She had colonoscopies in her 50s and 60s, and both were normal. No dangerous polyps, no bleeding, no unexplained weight loss, no family history of colon cancer. At her yearly appointment, a new doctor notices she has not had a colonoscopy in several years and says, "Let's repeat it." Helen agrees because she does not want to seem difficult. The night before the procedure, she takes the bowel preparation, but the prep is stronger on her body than expected. She becomes dehydrated. Her blood pressure drops. Her electrolytes become unstable. By the next morning, she feels weak, confused, and dizzy. Instead of going to the colonoscopy center, her daughter takes her to the emergency room. Now ask yourself, did that test protect her, or did the process create a new medical problem? This is not rare in older adults. The preparation itself can be difficult, especially for people with kidney problems, heart conditions, diabetes, frailty, or multiple medications. And the procedure also has risks. There is sedation. There is bleeding risk. There is a small but serious risk of perforation, meaning a tear in the colon. In a younger person, that is already serious. In an older adult, it can lead to emergency surgery, hospitalization, infection, or a long recovery. That is why many guidelines recommend being more selective with colon cancer screening after 75. Again, this does not mean everyone should stop. If you have symptoms like blood in the stool, unexplained anemia, persistent changes in bowel habits, or concerning weight loss, that is completely different. Those symptoms deserve medical evaluation. But if you are older, feeling well, have had clean colonoscopies before, and have no high-risk history, you should not be afraid to ask your doctor, "Do I truly need another colonoscopy at my age, or is there a safer screening option?" In many cases, stool-based tests may be discussed. These are non-invasive and may help identify warning signs without immediately exposing you to procedural risks. The point is not to refuse care. The point is to make sure the care matches your actual risk, your body, your age, and your goals. Because after 65, good medicine is not just about finding disease. Good medicine is about protecting your independence. Now let's talk about one of the most emotional topics in medicine, cancer screening. Because the moment people hear the word cancer, everything changes. Fear rises. Logic becomes harder. Families panic. And many patients feel that if a test can find cancer, then of course, they should do it. But after 65, and especially after 75, the truth becomes more complicated. This is Dr. Amanda Collins, and before I go deeper, I want you to hear this clearly. I am not against cancer screening. Cancer screening has saved many lives. Mammograms, colonoscopies, PSA tests, pap smears, skin checks, and imaging studies all have an important place in medicine. But the key phrase is this: the right test for the right person at the right time. A test that is smart at 50 may not be automatically smart at 80. A test that is essential for someone with a strong family history may not be necessary for someone with low risk and no symptoms. And a test that finds a slow-growing abnormality may start a treatment journey that causes more suffering than the condition itself. That brings us to checkup number 2. Checkup number 2, aggressive PSA testing and routine mammography in older, low-risk adults without symptoms. Let's begin with PSA testing. PSA is a blood test used to look for signs of prostate changes, including prostate cancer. It can be useful, but it can also be misleading, especially in older men. Why? Because many older men develop small, slow-growing prostate cancers that may never spread, never cause pain, never create symptoms, and never shorten their life. In simple terms, some men die with prostate cancer, not from prostate cancer. But once the test comes back elevated, the next steps can become stressful very quickly. The doctor may recommend repeating the test, then a specialist visit, then an MRI, then a biopsy. And if the biopsy finds cancer, even a low-grade cancer, many men feel pressure to treat it immediately. Now imagine a man named Robert. Robert is 78 years old. He is active, independent, and still enjoys working in his garage. He has no urinary pain, no blood in his urine, no bone pain, and no major symptoms. During a routine visit, his doctor orders a PSA test. The number comes back slightly high. Robert is sent to a urologist. A biopsy finds a very slow-growing prostate cancer. The doctor explains that treatment is available. Robert, hearing the word cancer, feels he has no choice. He chooses radiation. Months later, the cancer is controlled, but his life is different. He has urinary urgency. He wakes up multiple times at night. He feels exhausted. His sexual function has changed. His confidence has changed. And then he learns something that many patients only hear too late. His cancer may have been the type that could have been safely monitored instead of treated aggressively. This is the problem of overdiagnosis. Overdiagnosis means a test finds something real, but that something would never have caused harm during the person's lifetime. The diagnosis is technically correct, but the treatment may not improve survival, and the side effects are very real. The same principle can apply to routine mammography in older women, especially after 75, depending on overall health, life expectancy, personal risk, and previous screening history. Breast cancer screening is valuable, but in older women, mammograms can find very small, slow-growing tumors that may never become dangerous. Once found, however, they often lead to biopsies, surgery, radiation, hormone therapy, anxiety, and repeated follow-up visits. Let's imagine another example. A woman named Margaret is 81. She lives alone, still cooks for herself, and enjoys church on Sundays. She has had normal mammograms for decades. She has no breast lump, no nipple changes, no skin changes, and no family history of breast cancer. Her routine mammogram finds a tiny abnormality. The biopsy shows a very early, slow-growing cancer. Now Margaret is sent to surgeons and oncologists. She undergoes a procedure, then radiation, then medication that causes joint pain, fatigue, and hot flashes. Technically, the system treated cancer. But did the treatment give Margaret more meaningful life? Or did it take away energy, comfort, and peace from the years she was already living well? That is the question older adults deserve to ask. And this is where many people misunderstand prevention. Prevention is not simply doing every test available. Prevention means choosing actions that are likely to improve your future. Sometimes that is a screening test. Sometimes it is monitoring. Sometimes it is lifestyle. Sometimes it is treating blood pressure, improving sleep, correcting vitamin deficiencies, walking daily, preventing falls, adjusting medications, or managing diabetes. So what should you do? If you are over 65 or 70, do not simply ask, "Should I get screened?" Ask better questions. Ask your doctor, "What is my personal risk?" If this test finds cancer, what would treatment look like at my age? Would treatment help me live longer, or would it mainly create side effects? Is active surveillance an option? What happens if we monitor instead of treating immediately? These are not disrespectful questions. These are intelligent questions. A good doctor should welcome them. Because when it comes to cancer screening in older adults, the goal is not to find every abnormal cell in the body. The goal is to find dangerous disease early enough to improve life, while avoiding unnecessary harm from conditions that may never become a threat. And please remember, symptoms always change the conversation. If you notice a breast lump, blood in the urine, unexplained weight loss, persistent pain, new bleeding, severe fatigue, or any major change in your body, seek medical care. That is not routine screening anymore. That is evaluation of a real symptom. But if you are healthy, older, low risk, and being offered screening just because, pause for a moment. You have the right to ask whether that test is truly serving you. But this particular test can create one of the most dangerous cascades in older adults. Now let's talk about the heart, because when a doctor says, "Let's check your heart," most people immediately agree. And I understand why. Heart disease is serious. Heart attacks are frightening. Stroke is frightening. Nobody wants to ignore a silent problem. But here is the part many older adults never hear explained clearly. If you have no symptoms, some heart tests may create more confusion than protection. This is Dr. Amanda Collins, and checkup number 3 is one of the most common examples. Checkup number 3, routine cardiac stress testing when you have no symptoms. A cardiac stress test is designed to see how your heart performs under stress. Sometimes you walk on a treadmill. Sometimes medication is used to make the heart work harder, while doctors monitor blood flow, rhythm, and electrical activity. If you are having chest pain, unexplained shortness of breath, pressure in your chest, dizziness during activity, or symptoms that suggest heart disease, a stress test can be very important. But if you are an older adult with no symptoms, the story changes. Why? Because stress tests can produce false positives. A false positive means the test suggests something may be wrong even when there is no dangerous problem that needs intervention. And in older adults, this can happen more often because many people naturally have some age-related changes in their blood vessels, electrical patterns, or imaging results. The problem is not only the test, the problem is what happens after the test. Imagine a man named Charles. He is 73. He walks his dog every morning. He has no chest pain, no shortness of breath, no dizziness. He goes for a routine checkup, and his doctor says, "At your age, let's do a stress test just to be safe." The test shows a mild abnormality. Now Charles is worried. He is sent to a cardiologist. The cardiologist recommends a cardiac catheterization to see the arteries more clearly. That procedure involves placing a thin tube into a blood vessel, often through the wrist or groin, and guiding it toward the heart. It can be very useful when needed, but it is still an invasive procedure. There are risks: bleeding, blood vessel injury, abnormal rhythms, kidney strain from contrast dye, and in rare cases, heart attack or stroke. Then the catheterization shows a partial blockage. But here is something very important. Partial blockages are extremely common in older adults. Not every blockage needs a stent. Not every narrowing is the cause of symptoms. And for stable heart disease, many people do just as well with medication, walking, blood pressure control, cholesterol management, and lifestyle changes. But once a blockage is seen, many patients feel like they must fix it. So Charles gets a stent. Now he needs blood-thinning medication. His bruising increases. His bleeding risk increases. He has more appointments, more anxiety, more monitoring. And remember where this began. He had no symptoms. That is the medical cascade. Routine test, mild abnormality, invasive procedure, treatment, medication, side effects, loss of peace. This does not mean stress tests are bad. It means they should be used for a reason. So before agreeing to a routine stress test, ask, what symptom or risk factor are we investigating? What happens if this test is abnormal? Would the result change my treatment? If I feel well, would it be better to focus on risk reduction instead? Because for many older adults, the most powerful heart protection is not another test. It is consistent control of blood pressure, cholesterol, blood sugar, movement, sleep, smoking cessation, and medication review. Now let's move to checkup number 4, and this one is sensitive because it involves bone health. Checkup number 4, routine bone density testing that automatically leads to long-term medication. Osteoporosis is real. Fragile bones are real. Hip fractures in older adults can be devastating. So I am not saying bone health should be ignored, but I am questioning the automatic pipeline that sometimes happens after a DEXA scan. A DEXA scan measures bone density. It can help estimate fracture risk. For many people, especially those with previous fractures or high risk, it is useful. The problem begins when a scan result automatically turns into years of medication without a full conversation about the person's actual fracture risk, fall risk, strength, balance, nutrition, and overall health. Many patients are prescribed medications called bisphosphonates, such as alendronate or risdronate. These medications can reduce fracture risk in the right patients. But like all medications, they also have risks. Long-term use has been associated with rare but serious complications, including atypical femur fractures, which are unusual fractures in the thigh bone, and osteonecrosis of the jaw, a difficult condition involving bone damage in the jaw. Are these common? No. But are they important enough to discuss? Absolutely. Now imagine a woman named Linda. She is 74, active, and has never broken a bone. Her DEXA scan shows low bone density. Without much discussion, she is started on medication. She takes it for years but never receives a real fall prevention plan. Nobody checks her home for loose rugs. Nobody reviews her medications for dizziness. Nobody suggests balance training. Nobody checks her protein intake. Nobody asks about vision changes. Nobody helps her strengthen her legs. And then one day she falls. This is the point. In older adults, many fractures happen not only because bones are weak, but because falls happen. So if the goal is to prevent fractures, the conversation cannot only be about bone density. It must also be about fall prevention. Balance training matters. Strength training matters. Removing trip hazards matters. Good shoes matter. Vision checks matter. Adequate protein matters. Vitamin D, when appropriate, matters. Medication review matters, especially if you take drugs that cause dizziness, sedation, or low blood pressure. So if your doctor recommends a DEXA scan or medication for bone health, do not reject it automatically, but do ask, what is my actual fracture risk? Have we evaluated my fall risk? What benefits should I realistically expect from this medication? How long would I need to take it? What are the risks of long-term use? What non-drug strategies should I start immediately? That is a much better conversation, because after 65, strong bones are not just about numbers on a scan. They are about staying independent, steady, mobile, and confident. Now we need to talk about a test that sounds extremely logical at first, a test that many people accept because they believe it may prevent a stroke. And of course, preventing a stroke is one of the most important goals in older adult health. But this is exactly why we need to slow down and understand the risk. This is Dr. Amanda Collins, and checkup number 5 is routine carotid artery ultrasound screening when you have no symptoms. The carotid arteries are the large blood vessels in your neck that carry blood to your brain. A carotid ultrasound looks for narrowing or plaque buildup in these arteries. On the surface, it makes perfect sense. If a blocked artery can cause a stroke, then finding a blockage early must be helpful, right? Not always. This is where medicine gets more complicated. Many older adults have some degree of plaque or narrowing in their arteries. That does not automatically mean they are about to have a stroke. In many cases, the plaque is stable. It may have been there for years. It may never cause symptoms. But once it appears on a report, the conversation can quickly become serious. A patient may be sent to a vascular specialist. More imaging may be ordered. A procedure may be discussed. And in some cases, surgery may be recommended to clear the artery. That surgery is called carotid endarterectomy. It can be helpful for certain people, especially those who have already had symptoms such as a mini stroke, temporary vision loss, weakness on one side, or other warning signs. But for people with no symptoms, routine screening is much more controversial. Why? Because the treatment itself carries risk. Any procedure involving arteries that supply the brain must be taken seriously. There is a risk of stroke during or shortly after the procedure. There is also risk from anesthesia, bleeding, nerve injury, heart complications, and recovery problems, especially in older adults with other medical conditions. So imagine this. A 78-year-old woman named Evelyn goes to a community screening event. She feels fine. No weakness, no facial drooping, no speech trouble, no sudden vision changes, no history of mini stroke. The ultrasound finds narrowing in one carotid artery. Now Evelyn is frightened. She keeps thinking, am I about to have a stroke? She sees a specialist. More tests are ordered. Surgery is discussed. Her family becomes anxious. She feels like she is carrying a hidden bomb in her neck. But the narrowing may have been stable. It may never have harmed her, and the attempt to fix it may carry a greater risk than simply managing her risk factors carefully. That is why many expert recommendations advise against routine carotid artery screening in adults without symptoms. Again, symptoms change everything. If you ever experience sudden weakness on one side of the body, facial drooping, trouble speaking, confusion, sudden vision loss, dizziness with neurological signs, or a severe sudden headache, seek emergency care immediately. That is not routine screening. That is urgent evaluation. But if you are feeling well and someone recommends a carotid ultrasound just to check, ask, what symptoms or risk factors make this necessary for me? If it shows narrowing, what would we actually do? What is the risk of the procedure compared to the risk of monitoring? Can we reduce my stroke risk more safely by treating blood pressure, cholesterol, diabetes, atrial fibrillation, smoking, weight, and activity level? Because for many older adults, the best stroke prevention is not screening the neck randomly. It is controlling the major risk factors. High blood pressure is one of the biggest stroke drivers. Atrial fibrillation must be identified and managed. Blood sugar matters. Smoking matters. Movement matters. Medication consistency matters. Sleep apnea matters. And these are areas where action can truly change outcomes. Now, before we close, I want to give you a simple framework you can use at your next appointment. I call it the 5-question protocol. Whenever a doctor recommends a screening test, especially if you are over 65 and feeling well, ask these 5 questions. Question 1. What is the false positive rate of this test for someone my age? This helps you understand how often the test may create worry even when there is no dangerous problem. Question 2. If this test finds something, what would be the next step? This is crucial. Do not only think about the test, think about the chain of events after the test. Question 3. Would finding this condition actually change my treatment plan? If the answer is no, or if treatment would not be recommended at your age or health status, the test may not be useful. Question 4. What are the risks of the follow-up procedure or treatment? Every procedure has risk. You deserve to understand that before the process begins, not after. Question 5. Is there a safer, non-invasive way to reduce my risk? Sometimes the answer is yes. Medication adjustment, lifestyle changes, physical therapy, fall prevention, nutrition, exercise, blood pressure control, or careful monitoring may provide more benefit with less harm. These questions are not confrontational. They are not rude. They are not anti-medicine. They are exactly the kind of questions an informed patient should ask. A good doctor should not be offended by them. A good doctor should appreciate them. Because your health care should not be based on autopilot. It should be based on your age, your symptoms, your goals, your values, your risk level, and your quality of life. And that brings me to the most important message of this video. After 65, the goal is not to collect as many medical findings as possible. The goal is to live well, to stay independent, to protect your energy, to avoid unnecessary harm, to treat what truly needs treatment, to monitor what can safely be monitored, and to focus on the things that give you the greatest chance of living longer and better. Medicine has incredible tools, but even the best tools can cause harm when used without context. A test is not automatically good because it is available. A diagnosis is not automatically helpful because it is early. A treatment is not automatically wise because it is possible. The real question is, will this help me live better, longer, and more independently? If the answer is yes, then it may be worth doing. If the answer is unclear, you deserve a deeper conversation. And if the answer is no, then sometimes the most powerful medical decision is choosing not to start a cascade you may never have needed. If this video helped you see medical checkups differently, subscribe to the channel and join me here every week. My name is Dr. Amanda Collins, and my goal is to help you make calm, informed, confident health decisions after 60. And before you go, leave a comment below. Have you ever had a routine test that led to more tests, more worry, or a treatment you were not expecting? Your story may help someone else pause, ask better questions, and protect their health in a wiser way. Take care of yourself, and I'll see you in the next video.